Good afternoon, and welcome everyone to the Senate Committee on Health and Human Services for the 83rd Legislative Session. Madam Secretary, please proceed to call the roll.
Senator Lang. Senator Stone. Senator Taylor. Senator Titus. Chair Doniate.
And I'm here, and give me 1 second so I could just write one thing down real quick. All right, good afternoon, everyone, and thank you so much for joining us. Today, we do have 4 bill hearings on Assembly Bills 50, 176, 282, and 519. I'm going to go over the agenda order in just a second. For those of you who would like to testify on today's bills, we ask that you please sign in at the table by the door and provide a business card to the committee secretary. If you do not wish to testify, you may still want to sign in so that there's a record of who is interested in a particular bill in the event the committee needs to contact you. When testifying, please turn your microphones on to speak and off to listen. And we have listeners and viewers in Las Vegas and online as this meeting is being recorded. We ask that public comments be kept to 2 minutes so that everyone interested in speaking can be accommodated and we can get through the agenda in a timely fashion. And finally, we ask that folks please turn off their electronic devices, especially your cell phones, or put them on silent during the meeting. The order of today, we will do AB 50 first. This is the bill dealing with mass casualty incidents, seeing that there are folks that have a flight to catch, so we're going to try doing that one first. Followed by AB 519 by Assemblywoman Brown May. She has a hard stop at 5, and so we'll try to make sure that we get that done. The third bill will be AB 176, and then the last one will be AB 282. So that's the order that we have for today. Each of the bills will have a 15-minute breakdown, so 15 in support, 15 in opposition, and then 15 in neutral. And I'll rotate between here, Las Vegas, and then virtually as well. Let's go ahead and get started. I will go ahead and open the bill hearing on Assembly Bill 50, and we'll invite our co-presenters. This bill revises provisions relating to the victims of a mass casualty incident, and please begin when you're ready.
Hello, Chair Donate, members of the committee. My name is Ashley Kennedy, and I'm here representing Clark County. Today, I'm joined by our Clark County Fire Chief. I believe I see him in the room, Chief Billy Samuels, Misty Richardson from our Office of Emergency Management, and a very special guest, Candace Gumbs. We appreciate the opportunity to present Assembly Bill 50, which seeks to leverage technology to enhance emergency management. I want to share why we brought this legislation forward. In August 2018, nearly a year after the tragic events of 1 October, where 58 lives were lost and over 850 people were injured at the Route 91 festival, the Federal Emergency Management Agency, FEMA, Clark County Fire, and the Las Vegas Metropolitan Police Department conducted an after-action report. This report outlined key lessons learned, highlighting both what worked well and what we needed to improve. One of the most pressing challenges that emerged was victim information management, specifically knowing who was deceased, who was injured, who was missing, and which hospitals victims had been transported to. With the work of Misty Richardson and Chief Samuels, we looked for something that we can purchase off the shelf to use. We could not find anything, and so Clark County, in partnership with our IT department, created our own system, the Impacted Persons Database. The Impacted Persons Database was built to modernize what is currently a manual and fragmented process by using technology to ensure that all responders, whether on scene, at hospitals, in emergency centers, or assisting families, are operating with the same real-time information. At this point, I will turn it over to Ms. Richardson and Chief Samuels, who are the true heroes in this effort, who will share their experiences and the real-world challenges we're aiming to address.
Good afternoon. Thank you. My name is Misty Richardson, M-I-S-T-Y, Richardson, R-I-C-H-A-R-D-S-O-N. Thank you all for your time today in consideration of AB 50. This bill is the culmination of work and time invested by many multi-jurisdictional partners, both public and private sector. At the time of the Route 91 Harvest Festival 1 October incident, I served as the Assistant Emergency Manager, who was charged with the responsibility of opening up the Family Assistance Center. I was the receiver of the first 12 families that were sent to the Family Assistance Center before we were opened. One particular family had an elementary-age daughter who waited nearly 24 hours in unimaginable agony to get the information about her mother. She was covered in blood and sleeping on the floor during this period of time because we had no way to expedite the information to her family. They waited for their turn in agony for the notification that they knew was ultimately coming. As helpers, we couldn't help them. We were paralyzed by a lack of information and the coordination of that information. As a result, the after-action reports highlighted that the communication challenges with patient tracking and notifications was significant. Immediately after, we had meetings with federal health and human services authorities where we learned that HIPAA was not actually a barrier as was thought and what was used on a regular with the hospitals as we were trying to communicate with them. We spent 5 years searching for a tool that we could make patient tracking easier so that we could get this information to families faster. And we started with the end in mind. Once we found that we could not buy an off-the-shelf product, we started building our own, and we knew that the long-term recovery of those affected was significant. So we wanted to make sure that from the onset we had information sharing that went from agency to agency so that victims and survivors didn't have to regurgitate their stories over and over again. This is a multi-jurisdictional tool. It's a permission-based database. It is HIPAA and HL7 compliant, and it provides real-time information sharing for policy decision makers to be able to help people quickly instead of hours and hours or days beyond. In closing, this has been a 7-year in the making project. We have engaged with partners from around the state and have been recognized by federal authorities and industry leaders as the first of its kind system that will profoundly improve trauma-informed victim services. As a public safety community, we would appreciate your support. We thank you again for your thoughtful and kind consideration.
Ashley Kennedy, for the record. I will turn it over to Chief Samuels from down south.
Thank you, Ashley. Thank you, Chair and Committee. I apologize I'm not in there in person. I'd much rather be there with you guys. Like Misty said, I too was also part of the Family Assistance Center. I ran the operations component. And when those families came in, they were already grieving. And there's nothing worse to tell a grieving family is, I don't know where your loved one is. And that's really unacceptable. These incidents, they're occurring more often, more frequently, and they're going to happen again. And if we have the capability and the technology and the resources available and the partnerships that we have with the private and public, we need to make sure we can kind of get this information across the finish line. 18 to 24 hours is unacceptable. Put yourselves in those family shoes. And also put yourselves in our shoes when we're the ones that have to give that bad information to say we don't know. With the impacted person database, we do have the capability to actually, in a timely fashion with accurate information, let those loved ones know where their family members are. Again, I know you guys have busy schedules. I'm more than happy to answer any questions should they be, but thank you for your consideration. Thank you for your support and all the hard work that you've all done during this legislative session. Thank you.
Ashley Kennedy, for the record. Thank you, Chief Samuels. And at this point, we will turn it over to Ms. Gumbs.
Good afternoon, everyone. My name is, for the record, Candace Gumbs, K-A-N-D-I-S Candace Gumbs, G-U-M-B-S. I am here today to share a part of my story, one that forever changed my life and my family's life. On October 1st, 2017, my cousin Christiana Duarte, whom we lovingly call Chrissy, was one of the 58 innocent lives lost during the Route 91 Harvest Festival in Las Vegas. That night is seared into my memory. I was at home in California with my husband and our 4 children. We had just come back from my son's baseball game and getting settled into bed. Picked up my phone and I saw a Snapchat from Chrissy. It was a video of her and our family friend Ariel singing God Bless America, hugging and saying, "We love you and wish you were here." That was the last video I ever received from her. That was the last moment before everything changed. At 10:45 p.m., I got a text message from a family member letting us know that there had been a mass shooting at the concert Chrissy was attending, and that no one could reach her. She was missing. I remember turning to my husband and asking, "What do you mean missing?" The panic set in immediately. I called her phone again and again, over 40 times. Each time it just rang until it went to voicemail. I kept texting her, begging her to call me back to let us know that she's okay. For 18 agonizing hours, our family searched for Chrissy. We hoped, we prayed, we ran through every possible scenario. Maybe she was in a hotel, maybe a hospital, maybe she just lost her phone. But deep down, we feared the worst. I am a mother of 4, and I can't even begin to imagine what my aunt, Chrissy's mom, was feeling. The not knowing, the helplessness, the fear, it's an experience no family should ever have to endure. Chrissy was a vibrant, kind, and full of life. Her presence is still felt every single day. I share this story not just to remember her, but to remind us all of the very real, very human impact of gun violence. Behind every headline is a family left shattered, and behind every statistic is a name, a face, and a future taken too soon. This is why I support the implementation of the Impacted Person Database System. Had this been in place in 2017, it could have helped us reduce the agonizing 18-hour window of uncertainty. It could have brought us answers sooner. It could have given our family even a small sense of peace in the middle of an unimaginable pain. No one should ever have to wait that long to know if their loved one is safe or gone. Thank you for letting me share Chrissy's story and for listening with your hearts. Thank you.
Thank you, Ms. Gums, for sharing your story. In short, the AB 50 has a few key objectives. It provides a statewide framework for any county that wanted to establish a similar system. It provides immunity protections for a county to utilize such a system and requires hospitals to utilize a system during a mass casualty incident. In the Assembly, we engage with the hospitals to address much of their feedback, and AB 50 in its first reprint represents the results of those conversations. Chair, that concludes the bulk of our presentation. I'm happy to go section by section if you'd like.
Thank you so much for that presentation, and thank you for sharing your story with us. I think it's important for us to hear such stories, and we're so sorry for your loss, but clearly I think your family members would be very proud of you for doing this on behalf of them, and I'm sure that probably goes for a lot of the folks here today. Committee members, do we have any questions at this time? Senator Stone.
Well, thank you very much for the presentation, and fully support what you're trying to do. Can you just talk about the coordination with the hospitals, and are you contacting the hospitals, or the hospitals contacting you, incident related? How are the logistics of that going to work?
Ashley Kennedy for the record. I will start answering your question and may defer to Misty and Chief Samuels, but usually in an incident to this large of scale, we may have, what usually could happen is we stand up the multi-agency command center, MAC as we refer to it, to handle it, and that's where local resources are exhausted, where we have to pull in other jurisdictions. Usually as patients are being transported to a hospital, there is a radio system that notifies hospitals that to be prepared that incoming patients are coming, that some type of incident happened. So they're aware, and there's communication both from the first responder side to the hospitals, but I will defer to the experts who do this more.
Misty Richardson for the record. Senator, the system has been designed with the disparate healthcare systems that we have in Nevada. Most states will predominantly have one, maybe two that they use. We are different in the sense that we have 4 different hospital systems that we're working with in Southern Nevada. And as a result of that, what we have found is that each of them very similarly in their systems have already pre-built into their internal processes the ability to check a box that says that this patient coming in is a part of a mass casualty incident. So it's already something that is internal to their process. It's not something that is an additional ask for them. So What that does then is that information is transitioned into this database based upon the fact that that patient is an MCI incoming. So no additional labor, no additional work. It's not deviating from their already established processes.
Any other questions? I have a two-part one, if you can help me answer. One of them may be redundant, so I apologize if it's a little bit too specific. Are we referring to deceased victims or any victims of mass casualty incident? And the reason I'm going to follow up with based on your answer.
Ashley Kennedy, for the record, it would be all victims where they need to be reunified. They're using 1 October as an example. There were many victims who were not deceased, but were still a Jane or John Doe, where we didn't know who they were, and the extent of their injuries, they could have been incapacitated, and we didn't know who they were. So it's both deceased and living victims with severe injuries.
Thank you. The reason why I was asking that was now moving on to Section 3 of the bill. It says it only references a hospital or independent center for emergency medical care. And so I presume that there could be situations, for example, if I was at the event and I got trampled on, I might have gone to an urgent care or a different type of facility that does not meet the definition of what you're putting in. So I'm just wondering in terms of if there are other medical facilities that folks would look towards to receiving care that could be identified as victims without being fully cognizant and still being a part of this process. But I don't know if this bill prohibits those entities from participating and so forth, but it's more of a specific question.
Thank you, Chair. Ashley Kennedy, for the record. And that's a good question, and I would probably defer to the hospitals, but in my, I guess, basic understanding, in the event that somebody showed up to an urgent care center with substantial injuries, they likely would be transported to another hospital. And at that point, that's where this provisions of this bill would be triggered.
Thank you. And just to be clear, what we're talking about are victims who cannot be traditionally identified because either they're not conscious and so forth. And so that's most of the time, if they're not conscious, they're going to a hospital or independent center for emergency, right? You're not going to an urgent care for that case, but it's for the instances that you're not able to provide your own identification and so forth, so that we have an ability to contact or know where they're at, right?
Ashley Kennedy, for the record, that's correct. And usually, I shouldn't say usually, but under HIPAA, there are certain privacy standards related to disaster relief efforts. And so if somebody is conscious, the hospital will confirm that they do want to be in the database. Now, and at that point, it would be the patient's ability to object to being in the database. However, what we've experienced in helping victims from 1 October is there are times where victims are eligible to receive services. You'll hear from the Resiliency Center as an example that they may not want the services right away. So we did put a provision that anybody who was at part of an MCI at a hospital, they would have a unique identifier in the event that they needed those patient records for their services down the road, that there was a way to make sure that they were tied to that incident.
Thank you. Any other questions? All right, let's go ahead and open it up for testimony in support of the bill. As a reminder, I do have to unfortunately do a 15-minute cap on the testimony, and so it's a 2-minute per individual. Obviously, we have plenty of folks that want to participate today, so just be cognizant that there's other folks that will. Let's try our best to keep our comments short so other folks can participate. So I'll start the clock and start here in Carson City, and then I'll go down to Las Vegas.
Hi, thank you. My name's Larea Aristegi, for the record. I am the Deputy Family Assistance Center Manager in Clark County, as well as the Mass Victimization Advocate for the Clark County Fire Department. I responded on 1 October and assisted families through their coroner notifications and sat with those families for those extended hours. With lessons learned, we developed the impacted person database, and I can tell you that it is successful and it does work, because when the UNLV incident happened, the impacted person database was being utilized, and we were able to reunify those students and faculty members with their families and get those identified individuals who were deceased notified to their families within 6 hours. It was 540 people that we were able to reunify in 6 hours. It's substantially different than how it was on 1 October, and I hope that you support this. Thank you.
Thank you, Chair, members of the committee. For the record, Mike Cathcart, representing the City of Henderson. As a member of the Multi-Agency Command Center, the city believes this will be an important tool to have in the unfortunate circumstances when response to a mass casualty incident is needed. I want to thank Clark County and all the other stakeholders for their work on this legislation, and the City of Henderson is in full support. Thank you.
Thank you, Mr. Chair. Members of the committee, for the record, Kelly Crompton, representing the City of Las Vegas. I echo the comments that my colleague at the City of Henderson brought forward. I think this is an important piece of legislation, and as one of the members of MAC, we also support the bill. Thank you.
Hello, Minda Smith, MYNDA-SMITH. I live in Las Vegas. I am a sister of Nisha Tonks, who is one of the 58 victims. I am grateful for that day, for all of the people that helped, but it was chaos. My sister, I received a phone call from my 14-year-old nephew to tell me she'd been killed, and we had to start our journey of trying to find her. We were in the police headquarters, where we sat for 6 hours waiting for names to be collected from the hospitals. We sat for 3 readings of those names in the 5 hours that we were there, and no one was connected to any of the names that were read. We left and we went to my sister's home where we waited. My husband had been traveling to the coroner's office, the shooting site, searching for Nisha. No answers. We made it home, and at 9 o'clock at night, my husband finally just threw up his hands and said we were going down to the coroner's office again, where we were finally able to forcefully almost get our way into the coroner's office, thankfully, for a very kind assistant coroner, and finally find her. I am in support of the AB 50 bill. I think we need to find ways to reconnect families to their loved ones when those loved ones aren't able to. So I'm in support of this bill. Thank you.
And thank you for sharing your story, and we're so sorry for your loss.
I'm Mary Jo Vontillo. I'm the wife of Kurt Vontillo, who was also one of the 58. I was at the concert with 6 of my family members, and 3 of them were shot. My husband was shot fatally, and we knew it was fatal, but they forced us to leave the site, so we could not stay with him. That was on Sunday night at 10 o'clock. I did not get confirmation from the coroner's office until Tuesday night. So we did not know where he was, and all we would see was media coverage of the bodies still out there on the venue, and that was my biggest fear, that they had not collected him, and where was he? We did not know. So I'm in support of AB 50. If you could notify families as quickly as possible, it would help substantially. We went through so much just wondering where he was and who had him. So thank you. I appreciate your time today.
Thank you so much for sharing your story.
Thank you, committee members. Victoria Supple, representing Southern Nevada Health District today. Southern Nevada Health District serves as an emergency responder under the Clark County Multi-Agency Coordination Center. In that role, SNHD is tasked with locating patients within healthcare facilities who are victims of a mass casualty incident to assist in the reunification process with family members. During the response to the October 1 shooting, this process took weeks in some cases. Having a database where healthcare facilities can easily upload minimal necessary patient information will assist us in that effort and will aid patients and their families and will help families begin their process to recovery as soon as possible. We thank you for your time, and thank you to the loved ones of those who passed in the October 1 shooting for being here today and hearing this bill.
Good afternoon, Chair and members of the committee. For the record, Ryan Beeman, representing the professional firefighters of Nevada. Thank you for the opportunity to speak in support of AB 50. As a firefighter, I've witnessed firsthand the utter confusion and devastation that mass casualty incidents bring, not only to the victims, but also to their families, who struggle to locate and reunite with the loved ones after the aftermath. AB 50 proposes the establishment of an electronic database to streamline the identification and reunification process for victims of mass casualty incidents. This initiative is not just about data collection, it's about saving lives and reducing confusion and ensuring that families receive timely and accurate information when they need it the most. As firefighters, our mission extends beyond extinguishing flames. We are protectors and responders and advocates for the well-being of the community. AB 50 aligns with the mission by strengthening our ability to serve the public in times of crisis. I urge the committee to pass this legislation as it's a vital step toward improving Nevada emergency response infrastructure. Thank you.
Good afternoon. My name is Tennille Pereira, Tennille I am the director of the Resiliency and Justice Center, formerly the Vegas Strong Resiliency Center. I've been working with families since 1 October 2017 on healing and moving forward. For all the reasons the family members stated before, I support this, but also what the part that you may not be aware of is this allows us to provide long-term victim services. When people that are conscious are able to opt into the system, it then pushes it over to the Resiliency and Justice Center, and they have a connection now to long-term services. Many times, survivors of violence don't realize the impact the trauma will have on their life, often for years down the road. But when they do, they need to have somewhere that they can turn. They need to be connected to services. And that is also one of the functions of the Impacted Persons Database. So I hope that you can support it, and we appreciate that. Thank you.
Give me 1 second. If there's anyone in Las Vegas that would like to testify on the bill, you can come forward, but we'll take one. I just want to make sure that that was offered. Please proceed.
Hi, my name is Caressa Royce for the record. I'm here with the Forever One Memorial Group. I was critically injured on 1 October. I was routed to Sunrise Hospital, and I was unconscious for many hours, receiving critical care. My family was unable to find me. And I'm very lucky that when I woke up in the hospital, my mom was there. And I can't say the same for my fellow survivors that were injured. Some people waited in the hospital for hours alone and did not know what was happening. And it's really important that people are reunified with their families as quickly as possible. And to speak to what Tennille had said, I've been in advocacy for years since the event, and survivors come to me all the time and say, I wasn't ready to reach out for services in year 1, year 2, year 3, maybe it's year 5. And so people having access to that information through the database, right? The Resiliency Center shares so much information, not only on the anniversaries, but when other incidents happen that can be triggering for survivors of mass violence. They're able to reach out to the center and reach out to other resources locally. And it's really important that victims have access to long-term services. And I just want to express my support for this bill, and thank you for your time today.
Thank you for sharing your story and for being here.
Thank you.
Anyone else in Carson City? AVH, is there anyone online?
To testify in support on AB 50, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in support at this time.
Thank you so much. Let's move on to opposition. If there's anyone that would like to testify in opposition to this bill. I don't see anyone here in Las Vegas. AVH, is anyone online?
To testify in opposition on AB 50, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in opposition.
Thank you so much. Let's move on to neutral on this bill.
Good afternoon. My name's Patrick Kelly with the Nevada Hospital Association. Clark County reached out to us months ago, and we have been working with them and going through the bill. And it's a really complicated topic because it has a lot of federal privacy laws. We've gone through that, and there's just operational components. And they have been fantastic at working with us on that. So all is good in that respect. And I just want to thank them for doing that, but also want to answer your question. So typically what occurs is after one of these incidents, people come in and they might be unconscious, or they come in and they're conscious, but then we sedate them and they're kind of out of it for a while. So it's really, a lot of times we don't know who the people are because they don't have their IDs on them or anything like that. So it does take a while. So it is important to have these ability to connect, because what happens is all the people start calling every hospital, and you just get inundated with the calls, and we can't always tell them the information. So to have this central repository where we can send the information and tell people to call this number will be very helpful. Thank you.
Thank you, Mr. Kelly. Anyone else here in Carson City? I don't have anyone else here or in Las Vegas. AVH, is there anyone online?
To testify in neutral on AB 50, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in neutral at this time.
Thank you. Any closing remarks? At this time, I'm going to go ahead and close the hearing, and I believe Senator Titus has a few remarks.
Thank you, Mr. Chair. I think it's an important day here. This bill is very important to not only survivors, but I hope that it's not important to future events, that we don't ever have to use this. But in reality, we may. And so while the family members are here and I think the time is right, I would like to move that we put this into a work session now.
Thank you. So that's a motion to do pass, and I think we have a second
Correct.
from Senator Lang. Committee members, are there any comments that you would like to make at this time? Nope. All right. I'll go ahead and call for the vote. All those in favor, please say aye. Aye. Any opposed? The motion's carried, and I will assign that floor statement to Senator Titus. That concludes for that bill, so we'll move on to our next one. Again, to all the folks that came forward, we appreciate you coming to Carson City. And again, thank you so much for your advocacy, and we hope you enjoy your time here. All right, let's move on. As folks are transitioning, we will move on to AB 519. This bill creates a separate chapter of the Nevada Revised Statutes governing certain agencies and organizations that provide non-medical services, and I will invite Assemblywoman Brownlee to begin when she's ready.
That was very good. Thank you. Tracy Brown May for the record. Thank you so much for this opportunity to present Assembly Bill 519 for your consideration today. It looks like a really thick bill. We're going to walk you through it pretty quickly. So for the record, Tracy Brown May, I'm proud to represent Nevada Assembly District 42 in Clark County. I have two co-presenters with me today. We have Connie McMillan, who is here representing the Personal Care Association of Nevada, and where this initial issue was brought to our attention in the interim as part of a presentation that was made to the Joint Interim Committee on Health and Human Services. And Kate Morrison, who is with Maxim Healthcare. She's the Director of Government Affairs there, and a provider organization. As I stated during the interim session, the Personal Care Association of Nevada, or PCA, presented the Legislative Committee on Senior Citizens, Veterans, and Adults with Special Needs with information on how regulations impacted the personal care industry. This presentation covered how personal care services, or PCS, are regulated under Chapter 449 of Nevada Revised Statutes, which is the chapter that regulates medical facilities and other related entities. It's problematic for the Personal Care Association because their caregivers do not actually provide medical care. It's personal care. Because of this, the caregivers providing non-medical assistance are subject to regulations intended for medical care providers, which was onerous. Connie McMullen will walk us through a little bit of that, and then we will talk to Kate Morrison for just a minute, and then I'll walk you through the bill really quickly.
Good afternoon. I'm Connie McMullen, Chair Donati, and committee members. For the record, Connie McMullen, MCMULLEN, and I am testifying on behalf of the Personal Care Association, and I'll refer to them as PCAN. PCAN is in support of moving personal care agencies to a new chapter from Chapter 449, which is Public and Behavioral Health, and then it's regulated by Healthcare Quality and Compliance. Providers of PCAs, and I'm going to personal care agencies, are listed in Chapter 449 under medical facilities and other related entities, under that category of facilities for the dependent. But PCA is not a facility provider, it is a service provider. Since its inception in NRS in about 2004-2005, PCA has been listed under facility for the dependent. However, personal care is not offered in the same setting as a hospital or nursing home, which provides care in a brick-and-mortar setting. PCA offers non-medical in-home care services by caregivers, supervised and trained by a licensed agency for the aged and disabled. PCA caregivers are trained, background checked, fingerprinted, and provide non-medical activities of daily living and not skilled care. Regulations regarding training, such as cultural competency, infection control, and even immigration, to some degree apply to hospitals or nursing homes, the hospice, home health agencies, but they often do not apply or have limited application to personal care agencies. PCAM believes the creation of a separate chapter for the non-medical direct care workforce would more appropriately apply and should be extended to include the intermediary service organization referred to as ISO and the employment agency, both of whom work with placement of caregivers in the home similar to the personal care agency. All do the same service, but with a different approach. The need for this change is logical, coming at a time of increasing demand, caregiver shortages, and the increasing cost of providing care, all of which make it difficult to connect people to services in the home. Moving PCA, ISO, and employment agency to a new chapter would give the home care industry a better chance to expand growth in caregiving and provide better care for the consumer. We ask that the Senate Committee on Health and Human Services approve AB 519, and we thank you for consideration of our important bill.
Hello, my name's Kate Morrison, that's Katemorrison, and I am with Maxim Healthcare Services. Thank you for the opportunity today to testify on AB 519. This legislation authorizes the creation of a family home health aid program, also sometimes called family caregiving, for kids with medically fragile conditions. I'm with Maxim. We provide in-home skilled nursing care to medically fragile children and adults nationwide, and here in Nevada, we have 2 offices in Reno and Las Vegas. Private duty nursing, or PDN, is care in the home. It is an alternative to the hospital setting, and it is much more affordable as well. PDN care is the foundation of in-home care for families, and this critical service cannot be replaced. However, there is an opportunity to help supplement this service in specific circumstances when a PDN nurse is not available. This family home health aid program or family caregiving program will supplement skilled PDN care. The home care workforce, we know, is facing significant shortages of direct care workers, including home health aides, personal care aides, and private duty nurses. As a result of fewer available workers, long wait lists, many families are seeking the opportunity for parents and family members to work as caregivers and to fill this gap. This is particularly important for families in rural Nevada. AB 519 recognizes this need and desire from parents and creates a very specific framework for what this type of program can look like. We want to ensure that patients are safe, family members are trained, and there are adequate resources to families who take on this role. We are looking to help Nevada create a foundation of best practices that we've learned from all the states around you who have implemented this. We have some specific ideas if we get to that part. We're proud to offer family caregiving services in several nearby states as a supplement to PDN care. For many families, I've been told it's the opportunity to formally serve as their children's caregiver is rewarding, it's personally validating. It fills an important and necessary gap in care. Thank you again for the opportunity to testify and thank you to our sponsor again.
Tracy Brownman for the record. This bill picks up out of 449 everything that has to do with personal care attendants, and it moves it into its own chapter in Nevada Revised Statutes. So what we've essentially done with this measure is to take personal care attendants out of Chapter 449 and create its own chapter so that it can be regulated independently of medical care facilities. That's really what this does. We added an additional section, which includes, it's on page 93, the first reprint, section 120. It adds a member of the family as a recipient of Medicaid to serve as a personal care assistant. So it adds in a potential to train family members to function as a personal care assistant when necessary. That's the only change out of everything that took place. So personal care attendants into its own chapter so that it can be regulated independently. That's our bill presentation. We're happy to stand for questions.
Thank you so much. Committee members, we have questions. Got a couple of them. Vice Chair Taylor.
Thank you, Mr. Chairman, and thank you, Chair.
from the other house and those who presented. Just really a comment. This is, I actually have a bill as well that was really targeted towards, it wasn't the take it out of a chapter, but it also made it so that Medicaid would allow family members to give that home care, same training and all of that. So I see the intersection, and really yours is broader, but I just certainly see the need for that. So it's good to be a part of that. So thank you.
Thank you. Other questions, Senator Titus?
Again, thank you, Chair, and thank you for bringing this forward. I understand that there needs to be some clarification, but unfortunately, frequently in the families that certainly I know of, it's hard to separate just the personal care that sometimes they actually do have to do medical care. And then that which is why I believe in the chapter it is, and I'm a little bit worried about creating its own chapter because not uncommonly they are doing both. And how do you separate that then if they're giving insulin shots, they're doing finger tests, they're doing some of those things, they're changing catheters, they're changing wound care, all of those things. And I understand the ADLs, activities of daily living, which is just showering, getting them up, feeding them, all those things. But again, it's a fine line that frequently when somebody needs those type of cares, they also need X, Y, or Z. So how's that? So teasing it out makes me a little bit concerned.
Tracy Brown May for the record. Thank you, Senator. I sincerely appreciate that and agree with much of that sentiment, right? In my professional day job, I employ a workforce that are referred to as direct support professionals. They would also be personal care attendants. There are times when they do provide a level of care that would be considered more medical, but their training is such that it goes along with that. What we've done here is not necessary, so we don't want to regulate facility-based care in a medical setting as a personal care attendant. We want to regulate personal care attendants in that when they're delivering that level of service independently. I share the same concerns with regard to family members, right? Often you go over and above. And my family just came through hospice care, and my dad was a primary caregiver for my 88-year-old mom, right? So not just the activity of daily living, but her medication therapy and all of those pieces. Did he get her eye drops done appropriately, right? So follow-along services and partnerships where we have medical care and personal care, they walk together. What we simply want to do by creating its own chapter is give us an opportunity to regulate personal care attendants separately. Right now, a family caregiver can be licensed to provide care if they're employed by an organization that then is responsible for their training and compliance with the services that providing. My day job, we do that. I have family caregivers that have been certified, and they are required to do quarterly training to be in compliance with state regulations, but they are not monitored under 449. They're monitored under NRS 435, and they are employed through my organization in my day job. This would be very similar. Personal care associations would be required to ensure training is delivered and people are compliant with the level of care that they're delivering. So I share much of your concern. I think this gives us an opportunity to walk through what is a personal care attendant outside of a licensed medical facility.
So if I follow up, so based on this, they're not going. I just worry that they're going to then require that person that may do both things. They wear hats sometimes to be do a little bit more and say and not necessarily a family member, but they're now doing a diabetic testing, so they have to do that training. They're qualified to do that, and now they're under a different chapter, perhaps a different license, or now just a personal care attendant. And I just think there's gray lines there about what this care really says. Like somebody says, oh no, I can't do that. I'm strictly this.
Tracy Brown May for the record. Thank you, Senator. We have made no changes to the expectations of what personal care attendants do from the existing chapter that we have right now. The only thing we've done is we've taken them out of hospitals and medical licensed facilities, but it's the same expectation right now. What we want to do is be able to consider personal care attendants in that way. Personal care attendants are employed by organizations that are not hospitals, but they are personal care associations. Personal care is what they do, and they may have a component where they have nursing care. the nurses then walk alongside personal care attendants. And so it is a different job expectation, it's a different training component, and it is one part of the continuum of healthcare, which is why we wanted to be able to pull this out and regulate it independently of the existing medical chapter. It is still there, and it will continue to be considered, but as a different type of healthcare profession.
Any other questions? Just have a quick technical one. So just following up on Senator Titus's, they're still going to be under HCQC of DPABH and so forth. They're still going to be authorized to, in the same respect of being licensed and so forth, right? If there's malfeasance or negligence that comes up from personal care attendants, right? Like you still have to go through the same process. Is that correct?
Tracy Brown, Mayor, for the record, that is correct. Yes, each of the organizations will still be required to comply with all of the Nevada regulations that are in existence today.
So the argument pretty much, just from my understanding, is by moving it to a separate chapter, as was brought forward as a concern during the interim, is that sometimes when we pass laws, we don't intend it for the personal care attendants, we intend it for the institutions, right? And so by separating it now, if it is for the personal care attendants, we can delineate that in future laws as we draft them. But this is to ungroup them essentially.
Tracy Brown, Mayor, for the record, that is correct, yes. Oftentimes, personal care attendants are community-based care, not institutional-based care. We want to be able to regulate that within our community.
Thank you. The only other thing that I had a question on was obviously you mentioned page 93, the section 120 that adds in the members of family of a recipient. In the hearing of our vice chair, there was concerns as to sometimes, right? So there's like the two questions of like, can family members serve in this capacity, and to what extent could they qualify to be recipients of the funds and so forth, instead of having to be employed by facility or by associations and so forth. I think there was a concern that was brought forward in previous testimony during the session that perhaps it should be limited to immediate family members versus other types of family members, because traditionally they're the ones that are taking care of them. I don't know if this is something that you want to consider. I can send you the document that was sent to us earlier in session if you want to look up to it, because I think it was also addressed in yours, but I'm just giving you as feedback. So, and I don't know if that came up if folks have come up to you about this or in other cases. So.
Tracy Brown, May, for the record, thank you. No, we had not considered that, honestly. I have a niece who is a direct caregiver for her cousin, and they're familial, and they're within third degree of consanguinity. So it's like, I think we have to look at what is that? I mean, and she's like a certified nursing assistant, right, in California. Like, I think it's different regulations. I'm happy to consider that as we look at this.
Yeah, I'll send you the document so you can review it, and then you can make the determination. I was just flagging this for you as a conversation that came up. Did you want to say something?
Chairman Donati, it's already there under the ISO. The ISO program is designed for the person who receives the care to then be the boss of who is in line to take care of them. And if they are receiving state funds, the state acts as the go-between, the intermediary, to make sure that those funds are used appropriately. But they can hire whoever they want to. That's, I mean, it doesn't even have to be a family member. It can be a neighbor under the ISO program. Under the ISO program, they also can fill out a form and an affidavit that they are going to do skilled by unskilled, because sometimes family members do transition into needing more care. And that's a huge component of that, but that's only under the ISO program. The personal care agencies cannot do that. Although personal care agencies do hire one person to take care of their family, they do employ them. So yes, it's kind of complicated, but it already exists.
Thank you. Any other last minute questions? Let's open it up for testimony and support. If you would like to go ahead and support this bill, you may come forward. And I will put the time limit, as I mentioned before. I don't see anyone here. Is there anyone in Las Vegas? AVH, is there anyone online?
To testify in support on AB 519, please press star 9 on your phone to take your place in the queue.
Thank you, Chair and committee members, for this opportunity to address the Senate Health and Human Services Committee. For the record, my name is Jessica Fry, FRY. I am the Nevada Regional Service Supervisor for Consumer Direct Care Network. We are dedicated to serving Nevada, supporting 384 consumers and 442 caregivers. Nationally, we facilitate care for over 96,000 consumers through more than 126,000 caregivers across 14 states. And in 13 of these states, consumer-directed services operate under dedicated statutes reflecting the distinct nature of personal care services that these programs provide. I'm here to voice our enthusiastic support for AB 519, which creates a specific legal framework for personal care agencies in Nevada, aligning with national best practices. The main problem AB 519 tackles is the use of medical facility laws for personal care agencies, which are very different from medical facilities. This mismatch leads to unnecessary burdens and expensive compliance, taking resources away from direct client care. For instance, strict documentation requirements and staffing ratios meant for hospitals are impractical and inefficient for personalized home-based care. AB 519 provides a crucial remedy by establishing a dedicated statutory framework tailored to personal care agencies, and this legislation aligns Nevada with best practices observed in other states, streamlining operations and empowering agencies to better serve their clients. The passage of AB 519 will have a significant positive impact on both consumers and caregivers, and I please ask that you join me in supporting AB 519. Thank you for your time and consideration.
Chair, there are no more callers in support at this time.
Thank you so much. Let's move on to opposition. Is there anyone in opposition? I don't see anyone here or in Las Vegas. AVH, is anyone online?
To testify in opposition, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in opposition at this time.
Thank you so much. Anyone looking to testify in neutral on this bill? I don't see anyone here or in Las Vegas. AVH, is there anyone online?
To testify in neutral, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in neutral.
Thank you. Assemblywoman, did you have any closing remarks? All right. We'll go ahead and close the hearing on this bill. And thank you so much for joining us. And we will now move on to AB 176. This bill revises provisions relating to reproductive health care. And we will welcome Assemblywoman Torres Fawcett. Please begin when you're ready.
Thank you, Chair Zanyate and members of the committee. For the record, I'm Assemblymember Selena Torres Fawcett, and I represent Assembly District 3 in the heart of Las Vegas. I'm happy to be here to introduce AB 176, which in short establishes the Right to Contraception Family Planning Services Act. Before I get into the bill presentation, I do want to thank in advance and on the record the legal team for answering a good number of questions about this bill because I had several individuals reaching out wanting some clarification. And so with that, I'm happy and excited to present the bill before us today. This legislature has taken several important steps in previous legislative sessions to protect and expand our access to contraception. This includes Senate Bill 190 from 2021, which allows pharmacists to dispense contraceptives, Senate Bill 161, which expanded access to menstrual products, which required reimbursement to pharmacists for contraceptive services and required health insurers to demonstrate their capacity to adequately deliver family planning services, and SB 280, which of the 2023 session, which required hospitals to provide for the insertion or injection of certain long-acting reversible contraception if requested by a patient giving birth. For those of us who are in this building in 2023, this may be a familiar bill. It is a condensed bill from the provisions of AB 383 from the 82nd session, which was vetoed by Governor Lombardo. Unfortunately, the issue of access to essential healthcare services is just as pressing, if not more, 2 years later. In his veto message, the governor outlined two primary concerns. The first, that the bill would place any control over reproductive issues into the hands of state policymakers, which unnecessarily restricts local officials' autonomy, and the second, that the bill would likely expose government agencies and healthcare providers to costly litigation. Firstly, while the governor argued that AB 383 from the 2023 session infringes upon the autonomy of municipal governments, a lack of statewide framework creates a lack of cohesion in statewide healthcare policy. This may contribute to inequity between geographic regions and difficulty for healthcare providers who may be limited in their capacity to offer consistent care in the face of conflicting local regulations. A state-level approach ensures more comprehensive and equitable policy decisions in reproductive health care. In the veto memo, the governor proposes the example that this bill, the bill originally from 2023 session, AB 383, that bill could prohibit a local school district from creating a policy restricting a school nurse from providing abortion counseling and referral services. Just to be very clear, that the bill presented before you is not intended to change the obligations of schools. This committee will also note that the language was amended in the Assembly to clarify the distinction and prevent the provisions of this act from applying to schools. Therefore, the reprint and provisions of this bill excludes schools from the provisions of this act. So in no way does this bill impact or change any policy that would impact schools as it exists right now, or as it could exist unless a legislature it could come back in the future and then change that. But in this bill before you right now, it has no impact on school or the Department of Education. Further, we do not find increased litigation concerns to be a justifiable barrier in streamlining contraception accessibility. In fact, there is a higher likelihood of legal uncertainty when there are conflicting interpretations of rights across different jurisdictions because of inconsistent policies. While laws consistently face legal challenges, they should not be abandoned. Creating pathways for litigation can strengthen protections for patients and healthcare providers alike by establishing clear legal precedents and reinforcing the rights at stake. Therefore, a consistent statewide policy reduces ambiguity, ensuring contraception remains accessible, and that healthcare remains protected in the instability of the current political climate. Before I provide you a walkthrough of this bill, I wanted to make it clear what this bill does not do. This bill is restricted to contraception and family planning services. This bill does not address abortion. Section 7 of this bill, lines 26 to 27, state that this does not apply to NRS 442.250. This bill does not erode protections. On the contrary, it guarantees that we maintain our protections. This bill, as amended, clarifies that this bill does not apply to schools. Because of our work on this bill in the Assembly, AB 176 was able to pass unanimously, which means with complete bipartisan support in the Assembly. Today, I come to this committee asking for that same support. At this time, if the chair would like, I can walk through the sections of this bill. Section 2 states that the contents of this bill may be cited as the right to contraception and family. Oh, no, not necessary. There is an amendment that, thank you. Thank you for saying, I was ready. I thought he shook his head yes. So I will just go over the proposed amendment. It's a very simple amendment. It just changes the term reproductive health care to contraception and family planning services, which is aligned with the intent of this legislation. Thank you.
Thank you so much. Listen, if you want to stay here long, we're happy to stay here long as well. Well, we work until late. So, committee members, we have questions. Vice Chair Taylor.
Thank you, Assembly Member, and thank you for the work. I was here last session and saw all the work that went into that, and the fact that you were able to really work with those and so on and clarify things to get unanimous support. That is really impressive on this. But here's my question, Assembly Member. And I know you said that it doesn't apply to schools, right? But I just want to make sure and clarify. Does this have any impact? I know it doesn't apply to school nurses and so on, but does this impact at all the any of the sex ed policies or anything like that we have at schools?
Thank you. For the record, Assemblymember Torres Fawcett, through the chair to the senator, to make it very clear, absolutely not. AB 176 cannot be reasonably interpreted to prohibit schools from teaching about contraception as part of a sex ed course. And I actually specifically reached out to legal to see if this would conflict with any future sex ed law changes, and the answer is no. And I'm sure if the chair would like, I'm sure legal can continue to support that and provide more background.
No, I'm good with that. Thank you. I just wanted to be clear on that. So thank you so much.
Committee members, any other questions? Senator Tice.
Not really question, more of a comment. I have said many times the best way to prevent abortions is you prevent pregnancies. And I think having access to sound reproductive information and reproductive health is critical. So thank you.
We'll take that as a win. I have no other comment. Any other questions or comments?
Let's work session.
I'm not that generous. Only one.
All right, let's go ahead and open it. I don't think we have any other questions. Let's open it up for testimony and support. If you would like to testify and support, please come forward. Again, it's the 15-15-15 time limit.
Thank you, Chair and committee members. For the record, my name is Denise Lopez, Director of Nevada Campaigns for Reproductive Freedom for All. On behalf of the 60,000 members we have in Nevada, I'm here in support of AB 176, and I would also like to thank the Assembly member for this bill. We are here in support because we believe everyone should have the freedom to make their own decisions about if, when, and how to start a family or grow a family. This bill guarantees the right of every Nevadan to access contraception and family planning services without undue government interference. These decisions about reproductive health care belong to patients in consultation with their health providers and their family members. I'm also here because I've been denied birth control in the past, and I can't believe that in 2020, 2017, 20, whatever year it is, in our contemporary times, people are still getting denied birth control. And so I'm here in support. I urge you to pass this bill. Thank you.
Good afternoon, Chair Donate, Vice Chair Taylor, and members of the committee. My name is Jacqueline Nguyen, NGUYEN, with the Nevada State Medical Association. I'll keep it short. We ditto the previous testimony. The NSMA feels that access to contraception is crucial for reproductive health and overall well-being, so we are in support of Assembly Bill 176, and thank you to the Assembly member for bringing this. Thank you.
Barco Rauda, MARCO, RAUDA, for the record. I want to thank the committee. I especially want to thank the sponsor for bringing this bill forward. We've been working on this bill for 2 years. I also want to remind the Senate Minority Leader that we had a conversation about 383 a couple of years ago, and she was very instrumental and gave us a lot of really good advice after that, and we've taken that advice into this bill. So that's all. Just want to say thank you.
Good afternoon, Chair, members of the committee. My name is Davida Tyson, D-A-V-I-D-A, and I'm here on behalf of the Nevada Women's Lobby. AB 176 will safeguard access to contraception and family planning services in Nevada. The bill makes it clear that decisions about birth control, infertility treatment, and miscarriage care should remain between patients and their health care providers, not controlled or restricted. The bill reinforces that principle by preventing government interference and ensuring individuals have legal standing to challenge any barriers to care. This bill is both thoughtful and necessary. It focuses on protecting access to essential services. It's a balanced, smart step forward that reflects the values of medical freedom and personal privacy. We urge you to support AB 176 and help make sure that everyone in Nevada has the right to make decisions about their own health care without unnecessary interference. Thank you.
Good afternoon, Chairman Doniate and members of the committee. My name is Sarah Adler, A-D-L-E-R, and I am fortunate to represent before you today both NAPNA, which is the Nevada Advanced Practice Nurses Association, and the Nevada section of the American College of Obstetricians and Gynecologists, or ACOG. And for both of these organizations, we couldn't agree more with Senator Titus that family planning is a cornerstone of family success, and that is inclusive of contraception. So this bill is very valuable to the families in Nevada. Senator Taylor, we really appreciate ACOG having brought Assembly Bill 205 related to sex education. We super appreciate your question. We super appreciate the sponsor, her work on this bill and digging into that issue. And thank you to Legal for digging further. we agree, again, with Senator Titus that access to this information is absolutely critical. So it's a great bill. It's supportive of other legislation, the session and past sessions, and we're happy to be in support. Thank you.
Anyone else in support? I don't see anyone here in Las Vegas. AVH, is there anyone online?
To testify in support on AB 176, please press star 9 on your phone to take your place in the queue.
Good afternoon, committee. My name is Riley Svensson, RYLEY SVENDSEN, and I am the policy specialist with the Nevada Coalition to End Domestic and Sexual Violence. Reproductive coercion is a common tool that people who cause harm use to trap victim survivors in relationships and limit their autonomy. Families and medical appointments are costly, and people who abuse exploit this to exert greater control over a victim survivor. Not being able to decide if, when, and how you become a parent too often forces individuals to stay with perpetrators of abuse. An essential aspect of reproductive freedom is access. If a victim survivor loses access to critical health care, their risk for violence and further victimization increases. Reproductive coercion is abused, and when we deny victim survivors the autonomy to access their reproductive health care, it limits their ability to leave abusive relationships. AB 176 provides crucial protections for all Nevadans. It ensures that reproductive health care remains accessible and free from outside interference. When we limit individuals' access to make medically informed reproductive choices, those systems enable reproductive coercion to proliferate. By ensuring everyone has access to evidence-based medical care, we can create a healthier and safer Nevada. This bill is an important step in preventing violence and empowering victim survivors, and we urge you to support this bill. Thank you. Good afternoon, Chair and members of the committee. My name is Alexa Solis, ALEXA SOLIS for the record, and I'm the Interim Director of Planned Parenthood Voc Nevada, testifying in support of AB 176. AB 176 makes clear what Nevadans have demonstrated time and time again, that our state supports Nevadans' freedom to make their reproductive health care choices for themselves, and that includes decisions around contraception. I urge you to support AB 176. Thank you for your time.
Chair, there are no more callers in support at this time.
Thank you so much. Let's move on to opposition. Is there anyone in opposition? I don't see anyone here in Las Vegas. AVH, is there anyone online?
To testify in opposition on AB 176, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in opposition.
Thank you so much. Is there anyone in neutral on this bill? Please come forward. Got one here. And if there's anyone in Las Vegas, please come forward as well. Go ahead.
Thank you, Mr. Chair. Members of the committee, Melissa Clement, MELISSACLE-MENT with Nevada Right to Life. Our organization is neutral.
Thank you so much. Anyone in Las Vegas? I don't see anyone else. AVH, is there anyone online?
To testify in neutral, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in neutral at this time.
Thank you so much. Someone, do you have any closing remarks? All right, thank you so much, and thank you for joining us. I'll go ahead and close this bill hearing, and we will move on to our last one, which is AB 282. This bill revises provisions relating to billing for healthcare, and I will invite Assemblymember Ortlicker to please begin when you're ready.
Thank you, Chair and members of HHS. I'm Assemblymember David Ortlicker, representing District 20 on the southeast side of Las Vegas. And thank you for the opportunity to present Assembly Bill 282, which would ensure that patients receive refunds when they overpay their hospitals, doctors, or other health care providers. Unfortunately, some, I think it's a minority, of healthcare providers don't issue refunds when they realize they've overcharged their patients. This problem was brought to my attention by the Assembly member who preceded me in Assembly District 20, Ellen Spiegel, who will be speaking on Zoom. Ellen will share the challenges she faced when she overpaid for health care. Patients may be overcharged for a number of reasons, and an important one results from the fact that healthcare billing can be very complicated, as I'm sure Dr. Titus knows. And an important source of complexity comes from the different ways in which insurance plans require patients to share in paying for the costs of their care. For example, health insurance typically comes with a deductible, sometimes $500, maybe $2,000, and until patients pay down their deductible, they're responsible for the full cost of their care. Once the insurance kicks in, they pay their deductible, patients may have to pay a portion of the cost of care, maybe a flat fee of $25 or $50, maybe 20% of the cost of care, and maybe that 20% is for in-network care, and then it's 40% for out-of-network care. So this is all very complex. And so it's not obvious when the patient comes in how much they'll have to pay toward the costs of care when they see their doctors or go to the hospital. If it's January, patients still have their deductible to work down. They'll pay more than in December after they've exhausted their deductible. Or early in the year when they still haven't reached their out-of-pocket maximum, they'll pay more than later in the year when they've hit their cap on out-of-pocket expenses. As a result of this complexity, doctors or hospitals might inadvertently overcharge a patient, and that's typical. It's inadvertent. So I'll give you an oversimplified example to illustrate how a patient might be accidentally overcharged. So by the end of the May, our hypothetical patient has paid $1,500 toward a $2,000 deductible. So they have $500 less, and they see two doctors within a couple days. And each doctor, one on June 3rd, the next on June 5th, calls up in the insurer, and the insurer says the patient still has a $500 deductible and that the allowable charges for what these doctors are going to service will be $500. So the doctor reasonably bills the patient for $500. But Dr. 2's $500 is due from the insurer because through the Dr. 1, they would have paid off their deductible. But Dr. 2's not going to find that out. Who knows how long it takes for all the insurer to get back. But once the insurer gets back and says, actually, Dr. 2, we're going to pay you that $500 because the patient worked off their deductible with Dr. 1. And now Dr. 2's gotten $500 from the patient at the time of service. A month or two later, has gotten $500 from the insurer. And what AB 282 says, doctor, you have to refund that $500 to the patient. And of course, in most cases, the doctor will, or the hospital will, but not always, as you'll hear. And Ellen will now discuss her experience and what happened with her when she ended up overpaying.
Thank you, Assemblyman. And good afternoon, Mr. Chair and members of the committee. My name is Ellen Spiegel, and I approached Assemblyman Orentlicker about this bill after recovering from a serious medical issue. In 2023, my husband Bill and I changed our insurance to a high deductible plan with an HSA, which meant that for the first time, it was important for me to keep accurate track of our medical expenses. By the time I got to April 2023, I had paid nearly $10,000 out of pocket, which was obviously grossly wrong because I had a $7,000 out of pocket maximum. At first, I thought the issue was with my insurance company, but it turned out that I had a misconception about how insurance accumulators worked. At the same time, I was trying to get my insurance company to understand that I had spent way more out of pocket than I was supposed to I also went back to my providers to try to get overpayments refunded to me. I was having a very difficult time getting refunds sent to me because there is nothing in Nevada law that requires them to do so. I did everything I could, from sending letters and emails to making countless phone calls. I reached out to personal contacts asking for help. Once, while leaving a Las Vegas Aces game and walking through Mandalay Bay to the parking garage, I even asked for assistance from someone I knew who was a very senior in the administration of one of my providers that still owed me a lot of money. I'm going to use some actual dates and dollar amounts related to this provider so you'll see the impact that this bill can have on the lives of Nevadans. On March 29th, 2023, I paid this provider $1,457.75 as a deposit for treatment scheduled for April 5th. At the same time, I was told that my EOB would be finalized in May and that if I was owed a refund, I would receive it within 30 days of my treatment. On May 9th, the EOB was processed and my cost share was $255.36, which meant that I had overpaid $1,202.39. But I never got that refund or any written communication from the provider. When I called, all I was told was the EOB was being disputed and that I should be patient. The EOB was ultimately finalized on July 18th, and my final cost share was $181.06, which meant the provider owed me $1,276.69. So when did I finally receive my refund, and what did it take? I didn't receive my refund until November 16th, 232 days after I paid the deposit, and 121 days after the EOB had been finalized and the provider knew that they owed me that money. If AB 282 were the law, I would have had my refund by no later than September 16th, which is 60 days after the EOB was finalized. I also would have received written communications each month giving me an update and telling me why I was not getting the refund they had told me I could expect by May 5th. I mentioned earlier that my insurance company helped me get the most of my overpayments refunded. Sierra Health and Life has a rock star employee who looked at my EOBs and contacted providers to determine what I had paid them. When appropriate, she requested a refund for me. She was able to do this because I only used in-network providers and they all had contracts with the insurers. Additionally, she also discovered that a provider took a payment from the insurer and not only didn't credit my account with that payment, they charged me for it, resulting in a double payment of nearly $1,000. I had been trying for months to get that provider to reconcile their records with mine, and they refused to send me a coherent statement showing how they applied my prepayment to my account. While they sent me their internal ledger, it was nearly incomprehensible. The staff member of the insurer was able to make sense of it, and more importantly, the billing office listened to her when they would not listen to me. The same staff member also helped with another in-network provider who wanted to charge me $307.25 for a covered procedure, despite my having reached my annual out-of-pocket maximum. Put differently, whereas providers billed or wanted to bill me significantly above my out-of-pocket maximum, my insurer helped make sure that I wasn't being taken advantage of. As you know, when someone goes through a significant health issue, it's stressful on many levels. Knowing that you've overpaid your out-of-pocket maximum by thousands of dollars and not having the providers listen to you or communicate with you in writing just adds to the stress. Thanks to the Sierra Health and Life staff member, I recovered my overpayments and was finally able to focus on other things. But it shouldn't have taken my insurance company's intervention, just like it shouldn't have taken my approaching personal contacts to get back money that was owed to me. There needs to be something in law that tells medical providers they have to provide refunds of overpayments. I didn't just have issues in 2023, although that was probably the most dramatic. In 2024, one of my physicians closed his practice, giving no notice whatsoever, and I had been a patient of his for over 20 years. At the time he closed the practice, the patient portal said I had a credit balance of over $200. Despite making phone calls and sending messages through the portal, no one ever responded to me. Why? Because there's nothing in statute that says they must respond to me or refund overpayments. There isn't even anyone I can go to for help. I'm just out that money, as are any of his other patients in the same situation. In speaking with others about my experience, nearly everyone could tell me about a time when they too had overpaid a medical provider and didn't receive a refund, or received a refund out of the blue, usually with no explanation and months or years after the date of service. In other cases, they didn't learn they previously overpaid until they returned to the provider and were told there was a credit on the account which could be used for that day's copay. If you think about your own personal experiences and those of your close family and friends, you'll know how common it is that Nevadans don't get timely refunds of their overpayments or communications from medical providers, and you'll know the necessity of AB 282. Thank you very much for your consideration.
Thank you, David Orentlicker, for the record. Thank you, Alan, for sharing your experience. I'll now go through the provisions in the bill, which are based on legislation enacted in Minnesota. Section 2 discusses the obligations of hospitals and other healthcare facilities, and Section 3 discusses analogous obligations for doctors and other healthcare professionals. So they pretty much track each other, and I'll go summarize them and then say what the conceptual amendment does. So if patients think there's been a billing error and they notify the facility or the professional, the provider has 30 days to correct the error. If the patient identified a real error, they've got to correct it. Advise the patient that they need more time because they may still be waiting for the insurer, or refer the patient to the Office for Consumer Health Assistance, an existing office at HHS that helps patients with coverage concerns or billing disputes. So 3 things they can do: fix it, investigate, or refer. While the complaint is being investigated, the facility or provider can't bill the patient for this specific service under investigation, but they can continue to bill them for all other charges. Once a healthcare facility or professional realizes that they've been overpaid, they've done their investigation, or maybe they realize when they get the final explanation of benefits from the insurer that they have been overpaid, the facility or professional has 60 days to refund the overpayment. So if this bill had been passed before Ellen's case, the providers would have been obligations would have been triggered. They got the explanation of benefits. They realized that Ellen overpaid by almost $1,300, and then they would have paid Ellen. I've had a lot of help with stakeholders. Basically, the concerns were not with the concept, but the implementation. It turns out to be complicated, but fortunately, I've gotten very helpful input from the hospitals, the doctors, the chamber. I want to especially thank Pat Kelly, who provided language for some of our amendments. So what we've done to so some of the things we said is put a cap on the sanctions that they can have are in the conceptual amendment. They can be fined if a provider doesn't refund within the 60 days. They can be fined 10% of the overpayment, up to a maximum of $5,000. Now, you'll see in the conceptual amendment that I wanted to pay some interest to the patient, but I'm not sure that may be too complicated. So I think I don't think I'm going to suggest that. Just have the fine collected by the state. And then that, I think, was the main thing. Oh, there was, yeah, I think that's the main thing. So, but the main, as I say, the stakeholders were concerned about implementation. And I think we've gotten to common ground. There might be another tweak or two, but they'll tell us when they come up if there's anything else. So thank you again for hearing this bill, and happy to take questions.
Thank you so much for presenting. Let me take a stab at it first before folks have questions. I just want to make sure, I'm assuming we're all going to have the same ones. So let's break this down for folks who, just to understand the healthcare system, right? So patient comes in for a cough. So that's the service, right? You check in. Sometimes you either pay cash pay or they'll ask for your insurance. At that time, the front desk verifies based on your insurance benefits, right? They'll either the EHR pulls it up or they'll call manually. and they'll say, okay, this person has a $60 copay, right? Or sometimes it's even on the card, depending on it is. So that's the point of service. After you leave, your doctor then bills for that service, right? So they submit the CPT codes, et cetera, that they provided you, whatever level of treatment for whatever you came in. At that time, right? It could be 30 days, it could be 60 days, it could be 120 days. We may never find out. That we will send it into the insurance company, and then at some point in time, we will receive an EOB back to the doctor's office notifying us that they're paying us a certain amount. And so at that point, right, there's either an overpayment or an underpayment. If there's an overpayment, traditionally the billing office or the person that's in charge in the billing office will contact the patient and notify them that there's an overbilling, and they will tell them two things. Either you can use it as a credit for your next visit if you need it, or you can get a refund. Or if there's an underpayment, then we would notify the patient, because then they need to come back to pay for whatever the insurance company did not pay. And then it goes back to the dispute of like going to the insurance company and going for investigation and so forth. But I just want to make sure that we all knew that that's traditionally the basics of the service. I guess the question is, I know that the bill has like scenarios of when the person can when they can insert themselves to further investigation and so forth. And so I guess my question is would it just be easier to just say when a final determination is made for an adjustment with an EOB, right? So the EOB is finalized. There's nothing else that the insurance company will review it for. At that point in time, the patient has the ability to come back and say, my insurance company has confirmed that this is what's going to be billed. The doctor does have the ability, they did over collect. I am entitled to a refund. And then at that point in time, the doctor has a certain amount of time to respond. And if they don't respond, then they can go for we can refer to disciplinary action from the Board of Medical Examiners or whoever. Is that not just easier instead of going into the details of the fines and so forth? Because at that point, it's the provider not responding to you for it. I'm just saying, I don't know if the bill language makes it more complicated than it needs to be. Certainly, I think patients should be entitled to their refunds if they overpaid, but I don't know maybe if Senator Titus has other remarks as well, being in the position, but I don't know if the bill makes it more complicated than what it needs to be, and perhaps maybe you can talk to us about some of the conversations we've had.
Yeah, it's a good question. David Orient-Licker for the record. Thank you, Chair. So what you're suggesting, I think, is captured in sections 2, subsection 4, and then the corresponding 3, subsection 4, that once the provider realizes that there's been an overpayment, they have to refund the overpayment. But the reason why I went in, the bill goes into more, is it occurred to me, so the genesis for the bill, as Ms. Spiegel explained, was that we have the problem that she had overpayment, not return. But there may be other problems. There might be billing for a service that was never provided. The patient might get a report from the insurer that says the doctor billed for a service on a certain day, and the patient realized, I never went to the doctor that day. So I didn't want to, if we're going to address the problem of billing errors, I wanted to cover other possibilities. So that's what makes it more complicated.
Thank you. Questions? Maybe Senator Titus, if you want to chime in.
Yes, thank you, Mr. Chair. First, I want to acknowledge Helen Spiegel there. I mean, we served together, and it's good to see you, and hopefully you're doing well. I do have a couple questions. I have some concerns and just some acknowledgement. When I started practice, it took me 6 months before I got my first check from any insurance company. So there was a long time there before they reimburse, and it can be very delayed, especially Medicare. It can take a long time because they will deny a claim, and then you have to justify the claim, you have to send more information, and so there can be an extreme delay in just getting any reimbursement from insurance companies. And so I worry about a timing of any reimbursement or any decision. So I like the open-endedness, and the one thing about as soon as a final decision has been made and you get this is what we're paying for, because it can take literally years. It can take a long time. My concern is that as a provider, in many instances, they're an employee of a facility. They are not the person, and you say the providers, but frequently, very few people are in private practice anymore, and they're not the ones doing the billing. As a matter of fact, for the most part, we never know what the billing is and what it's paid for unless the person in billing comes to us and says, hey, you have to put a different code in, you have to redefine that. Otherwise, we don't know whether it gets billed or not. So I'm curious about how that works, and I'm very concerned about the way this wording is. It really puts, quote unquote, the provider, whether it's a PA, a nurse practitioner, whatever, in pretty significant, in my mind, liability by this particular bill for something that they may not have any idea on. And so I'm very anxious. Could you address that? If because it talks about if a bill from a provider of healthcare, as a, and so I'm worried that frequently we turn it over to, say, a collection agency. We don't even know what that process is. So can you give me some reassurance?
Absolutely. Thank you for the question, David Orentlicker, for the record. So, yes, this concern was brought to us by Ms. Wynn from the State Medical Association and others. And so if you look at the conceptual amendment, the last section on the conceptual amendment that's titled Section 3.5, what we say there, what the amendment will do is that if there has been a failure to send a refund by a healthcare professional as opposed to a facility, the fine will be imposed on the entity that does their billing. Because as you say, often they have no idea what's going on. So rather than penalize the doctor or the nurse, the fine will be imposed on the billing entity. And I hope that addresses the problem.
Thank you, Mr. Chair, and thank you, Sarah, because I just absolutely have to make it clear that the providers are frequently have nothing to do, and not only that, frequently even these big medical groups have billers in another state. They're not even close to having anything to do with their individual group, and so it may not even be that the term medical facility is appropriate, or the biller. It should be the billing agency as opposed to the healthcare provider or the hospital or whatever. Whoever the billing agency is may be better for this than any provider, medical facility. And it's not just healthcare. There's many things now like that offset their whole billing practices in other states. So I just have big worry about this. Thank you, sir.
Did you have anything that you wanted to respond as a member? I think the only challenge that I would say is oftentimes, I'm not saying all providers do this, but there are some providers that use offshore billing companies. And so how do you go after them though? So like at the end of the day, right, as if you own a practice and you are delineating the responsibilities of your practice to, say, a billing company, you're still responsible for the level of care that's for your facility, regardless of the biller that you're using and so forth, right? Whether it's an offshore company or someone that's employed by you, it's still your facility. So I understand the sentiments of provider of care versus facility, but ultimately it's the facility that needs to have the responsibility, especially if I overpaid, right? I guess the question, instead of having patients go from one place to another, someone has to be responsible in terms of responding to them. And traditionally, it's the owner of the facility and so forth. Yeah. Yeah. Any other questions? Did you have another one, Senator Tice?
Well, from a comment, I just think, for me, if the bill just said that if a patient has, once everything is done, settled regardless of bill, and they have overpaid, and the determination, they have to be reimbursed in 90 days, whatever. And if that's all this bill said, I think that's appropriate. I mean, I've gotten, my dentist mailed me a check for $1 the other day because I overpaid. I didn't even know I had overpaid it. You know, there are providers who do a great job. Why am I getting this $1 check? But there are some don't do a good job of it. And I hear what has been said. And if that's all this bill did, would just say, listen, once everything's been determined, the patient must be paid within 90 days. Without putting anybody else, you know, that's just end of story. And then looking at some teeth, I have a lot more comfort with it, but currently it makes me a little anxious.
Thank you. I think that's a fair recommendation. Perhaps we can talk about it offline. Again, the simplicity is patients deserve, if they receive the service, right, and they overpaid, they deserve a refund. I think all of us agree to that point. And so we'll just have to talk offline in terms of what we can get there. Yeah.
Yeah, David Orentlicker for the record. Absolutely happy to have that discussion. Why that's there is the sense that you have to have some enforcement for the bad actor. But happy to discuss it because this is where all of the work with the stakeholders is focused on. So happy to continue that.
Great, thank you. Any other comments? Let's open it up to testimony. If you would like to offer support testimony at this time, please come forward. I don't see anyone here or in Las Vegas. AVH, is there anyone online?
To testify in support, please press *9 on your phone to take your place in the queue. Caller, you are unmuted and you may begin.
Hello, my name is Heidi Sterner, HeidISterner. I am representing not only myself today, but also the Nevada chapter of the National Association of Benefits and Insurance Professionals, also known as NABIP, N-A-B-I-P. NABIP Nevada represents the thousands of licensed professional health insurance producers, brokers, and agents licensed in this state, helping employers, individuals, and Medicare beneficiaries to review, purchase, and use their health insurance benefits throughout the year. On a personal level, I am currently dealing with this exact situation today. I recently had knee surgery, and I prepaid the surgeon and the ambulatory surgical center. Unfortunately, due to the order in which the providers filed their claims, it has resulted in my overpaying the surgeon and one of the providers, the surgeon, from my HSA card. I am currently waiting for that entity to refund my HSA card so that I may use those funds to pay the anesthesiologist that did not require the prepayment. As a health insurance producer and a member of NABIP Nevada, we're used to this and we are very empathetic of consumers who experience situations like this because we help clients routinely with issues just like this on a day-to-day basis. While I personally am not significantly financially harmed because my monies came from an HSA account dedicated for my cost share of claims, many Nevadans are put into financial bind when they overpay and have to wait lengthy periods of time for their own money to be refunded to them. NABIP Nevada members work on a daily basis to provide education and support to Nevadans regarding how their specific health insurance plans work, educating them from which providers are in network, which medications are covered, et cetera, including helping them with their claims and filing appeals when claims are denied and getting refunds from providers when they're overpaid. It is vitally important that Nevadans be refunded within a reasonable time frame if they have overpaid a provider for whatever reason. When our clients pay for healthcare services, they do so in good faith. We support having providers refund in good faith and in a timely manner. We would like to thank Assemblymember Orentlicker for bringing this bill forward, and we urge the committee to support AB 282.
Chair, there are no more callers in support at this time.
Thank you so much. Let's move on to opposition testimony. If you would like to oppose this bill, please come forward. And you may begin.
Good evening, Chair Doniate, members of the committee. For the record, my name is Nick Schneider, Director of Government Affairs for the Vegas Chamber. Wanted to start off by just thanking Assemblyman Ornlicker for working with us through this process. With the adoption of this amendment, we would be happy to move to neutral. Thank you so much.
Thank you. Anyone else? AVH, is there anyone online?
To testify in opposition, please press star 9 on your phone to take your place in the queue. Chair, there are no callers in opposition.
Thank you. Let's move on to neutral testimony.
Good afternoon. My name is Patrick Kelly with the Nevada Hospital Association. When this bill first appeared, we had a lot of concerns about it, and a lot of the same issues that you brought up here, but the sponsor has been really good at working with us. We've been going back and forth on this bill for a long time and entertaining our amendments that we've offered, and I think we're in a pretty good spot at this point. So thank you.
Hello, Chair and members of the committee. My name is Jacqueline Wynn with the NGUIN, with the Nevada State Medical Association. Again, thank you so much for all the comments that you said. It is a complicated system. I've spent many, many hours recently trying to learn the billing system and how it goes through the channels from a solo practice to a large group medical practice, and it's incredibly complicated where people, you know, those billing people, the billing departments actually get certified to do this, and certainly my doctors don't understand it. The issue that we had initially specifically came from our employed members. Our employed members said they have absolutely no hand in the billing, nor even if a patient came in and said to, you know, Dr. X, you overpaid me. If that doctor went down to the business office and said, okay, go ahead and send them a refund, they're like, no, you have no jurisdiction over this at all. So we are very thankful to talking to Assemblymember Ornlichter for addressing that concern. So it was not elegant language, but it was from us that it said the billing entity, and we weren't really contemplating third-party billers. We were actually contemplating the employer as the billing entity. So that if the billing entity, big group company A, was responsible for the billing and a fine was assessed, it would be assessed to that billing entity rather than the physician that provided the services but didn't actually do the billing. So with this amendment, we today are at neutral, so thank you so much.
Can I ask you a couple questions? I know, so it's neutral support, or sorry, it's neutral testimony with regard to the amendment that was added on today.
Correct. With the amendment, I'm sorry, should I have been?
No. Just
okay.
well, because this is where my question comes in. In Section 3 of the bill, it switches it from medical facility to provider of healthcare, but it sounds like that's contrary to what you're saying. So that's why I'm trying to understand. Are you okay with that section, with that change?
So I think actually that section, it said medical facility as a mistake. I think that section originally was supposed to be provider of healthcare, and so when it was rewritten. Is that? Sorry, Jacqueline Wynn for the record. So yes, I do understand that the way the bill is written as well is the first section is if the provider overcharges and if the provider overcharges, but we were concerned about the penalty portion, that the penalty then goes to the billing entity, but maybe that has to be massaged a little bit more to really differentiate between the individual provider that provided the service versus the group practice that provided.
Yeah, I think I guess the only issue, right, if you were the biller in that scenario, you would say, I don't have any of the money. I'm just the one that bills the service, right? I'm the one submitting the claims. So who, like, it's the provider that collected those dollars, right? So I guess that's.
So Jacqueline Wynn for the record. Again, it's not the biller meaning a third-party billing company. It means, so for example, there's a large, reputable healthcare organization in Southern Nevada that employs 15 physicians. It would be that organization that got the fine rather than the individual 15 physicians. I'm hoping that clarifies.
And not the biller, correct?
Correct.
It's just the entity that is sending the tax ID over, et cetera.
Correct. So my understanding is that healthcare organization has the contract with the payer, and then all the 15 are credentialed under that contract. So it should be whoever has that contract with the payer is responsible for the fine.
Great, thank you. Just want to double check.
Thank you so much.
Any questions? I think you answered them, so we just wanted to make sure. All right. Anyone in Las Vegas for neutral, and AVH, anyone online?
If you'd like to testify in neutral on AB 282, please press star 9 on your phone to take your place in the queue. Caller with the last 3 digits, 490, please press star 6 to unmute yourself.
Cyrus Hojati, Hojjaty. I was going to originally be neutral because it had no votes on both parties, but I'm going to be on support if that's okay. Thank you so much. Is that okay if I testify in support?
Yep.
Okay. Yeah, just ditto. Thank you.
Thank you so much. All right. AVH, is there anyone else?
Chair, there are no more callers at this time.
Thank you so much. Unless someone has any comments, I'm going to go ahead and close this hearing. And we will now move on to the last agenda item, which is public comment. I don't see anyone here or in Las Vegas. AVH, is there anyone online?
If you'd like to participate in public comment, please press star 9 on your phone to take your place in the queue. Chair, the public line is open and working. However, there are no callers at this time.
Thank you so much. That concludes the work of today, and we look forward to seeing everyone on Tuesday. Meeting is adjourned.